Thank you, Liz, for that very informative presentation. My presentation is going to cover a number of clinical trials that have been published in the recent years that use the data that Liz just described in detail to support prospective monitoring for breast cancer-related lymphedema. I'd like to start with going back to 2014, when Dr. Attila Soran from the University of Pittsburgh Medical Center published his work on the importance of detection of subclinical lymphedema for preventing breast cancer-related lymphedema. The aim of this study was to look at a group of patients undergoing axillary lymph node dissection and prospectively monitor them with bioimpedance spectroscopy and compare that group to a well-matched control group where tape measure was used to monitor the patients. The L-Dex group consisted of two subgroups, one where the patients had preoperative reading and one where the first measure was post-surgery, but they showed no signs of clinical lymphedema. If a patient in either L-Dex group had a score of greater than or equal to 10, or the L-Dex score was greater than or equal to 10 from baseline, they were referred for early intervention. Now this is where it gets a little tricky. I just explained that the L-Dex group was broken into two groups, but in fact there were three groups in this study. There was also a control group, 44 patients who had a pre-op L-Dex and tape measure, but were then followed with tape only. There were 72 patients who had pre-op measures and were followed prospectively with L-Dex, and this formed the pre-op group. There were 64 patients who did not have a pre-op measure, but were followed prospectively with L-Dex. The data shows these groups were well matched, but not randomized. The mean follow-up time in the pre-op group was 19 months, post-op 25 months, and the control group 19 months. The incidence of chronic lymphedema in the control group was 36.4%. In the pre-op group, the incidence of subclinical lymphedema was 38.9%, with two patients in this group progressing to clinical lymphedema during the follow-up period. This resulted in the incidence rate of clinical lymphedema in the combined pre-op and no pre-op groups of 4.4%. Soran concluded that the detection of lymphedema in the early subclinical phase, combined with timely intervention, led to a reduction in the incidence of clinical lymphedema from 36.4% to 4.4%. In 2018, Kilgore from the University of Kansas Cancer Center took a retrospective look at their prospectively collected data. 146 patients at high risk of breast cancer-related lymphedema, including based on similar inclusion criteria to the PREVENT data, which I'll discuss later. The pre-op measures were obtained and at least two follow-up measures. Routine surveillance was performed at regular intervals out to 2 years, and patients diagnosed with lymphedema were started on standardized home conservative interventions, including the use of routine compression garments and patient-directed self-massage for a period of between 4 and 6 weeks. The results showed a similar incidence of breast cancer-related lymphedema as Soran, with 49 patients, or 34%, developing breast cancer-related lymphedema. With treatment, 82% of these patients returned to baseline. All of the 9 patients who did not respond to treatment had significantly more positive lymph nodes, and 6 of the patients actually died as a result of their breast cancer. The table on the right shows resolution based on lymphedema stage at the time of detection, and really shows that those patients that are detected at a subclinical stage or stage 1 have a much better response than those who are detected at stage 2 or stage 3. So these findings show the benefit of early intervention and support the use of prospective screening and intervention. They demonstrated that early detection with patient-directed intervention improves outcomes and decreases the risk of persistent breast cancer-related lymphedema. The next study I would like to discuss is the PREVENT trial sponsored by ImpediMed. It's a large multi-centre randomised control trial which is currently underway at a number of institutions in Australia and the United States. The coordinating site for this study is Vanderbilt University, and the lead PI is Professor Sheila Reidner. The primary aim of this study is to answer the so what question. It is well established that L-Dex is able to detect extracellular fluid accumulation, but we are often asked if detection at a subclinical level makes a difference to patient outcomes. Therefore, the aim is to determine if the rate of progression to requiring complete decongestive therapy, or CDP, for clinical lymphedema can be reduced when you use this compared to tape measure. There are a number of other secondary aims, including looking at the risk factors such as obesity, smoking, and air travel. We're also looking at time to progression to CDP, as well as patient surveys on skin condition and quality of life. The study has 2 time points to determine eligibility. The first is following cancer diagnosis, but prior to surgery, when a patient must have confirmed invasive breast cancer or ductal carcinoma in situ, DCIS. They must have planned surgery, they must be greater than 18 years of age, and also have the ability to understand the requirements of the study and be willing to sign a written informed consent document. Following surgery, at 2 months post-op, patients are again assessed for eligibility. The first criteria is stage 1 to 3 invasive breast cancer or DCIS. In addition, they must have at least one of the following criteria: total mastectomy and/or axillary treatment with at least axillary dissection or sentinel lymph node biopsy with greater than 6 nodes removed, and/or radiation therapy to the chest, breast wall, or axilla, and/or taxane-based chemotherapy. So as you can see, there are quite a few options for inclusion in the study. There are 1,100 women in this study that were randomised into one of 2 groups, monitoring with L-Dex or monitoring with tape measure. Measures were taken preoperatively at 3, 6, 12, 15, 18, 21, 24, 30, and 36 months post-operatively. It must be noted that the 15 and 21-month visits were optional if it coincided with a patient clinic visit or for other reasons. Each patient had both measures taken preoperatively and at certain other designated time points in the study, such as when they triggered an intervention or at the end of the follow-up period at 36 months or at another endpoint in their place in the study. If the patient did not experience lymphedema or progression to lymphedema, their follow-up continued for 36 months. Intervention was prescribed if in the L-Dex group if the score was greater than or equal to 6.5 above baseline, and in the tape measure group between 5 and 10% volume increase from baseline. The 6.5 change came about after the first publication, which I will cover later. Intervention consisted of 4 weeks of compression sleeve and gauntlet of 23 to 32 millimeters of mercury tension. It was worn by the patient for 12 hours while awake, and these garments were provided by Medi. Following the 4 weeks of intervention, the patients were remeasured, and if there was a decrease, they continued in the study. If there was an immediate decrease, but at some subsequent stage in the study they had a recurrence, they were immediately referred for CDP. If their volume post-intervention was greater than or equal to 10%, they were immediately referred for CDP. Once a patient had triggered an intervention, they were only followed with tape measure. So if they were in the L-Dex group, they switched to the tape measure group. The first publication to come out of this data was to look at the trigger value for L-Dex. When the study was originally designed in 2014, a score of greater than or equal to 10, or 3 standard deviations above baseline, was the trigger criteria for intervention. As explained by Liz in her previous presentation, the school of thought is now a 2 standard deviation change of 6.5 is more appropriate. Data from the PREVENT study actually reinforced this finding and also supported frequent measurements in the early stages post-surgery. Now to the interim analysis of the PREVENT data. The main aim of this study is to look at the outcomes, and the protocol defined that we would perform an interim analysis once the first 500 patients had completed 12 months participation in the study. This manuscript was published in the Annals of Surgical Oncology in 2019 and presented as an oral presentation at the American Society of Breast Surgeons scientific meeting at the same time. What it showed was the results support the use of subclinical detection, and if the rates remain consistent, we will reach statistical significance in the 3-year follow-up. The authors also concluded that these early results were positive and practice changing. So what did the data actually show? It showed that 109 patients triggered an intervention, which was 21.8% of the population. Tape measure accounted for 68 of those patients and 41 in the BIS group. Overall, 12 patients required CDP, 10 or 14.7% from the tape measure group, and 2 or 4.9% in the BIS group. Due to the small numbers, these results are not statistically significant, but were thought to be clinically significant. The subclinical lymphedema rates are consistent with the current literature, and most importantly, L-Dex didn't trigger interventions above expectations. The final paper I want to discuss is one published just this year by Louise Koelmeyer at Macquarie University. This paper was to look at the differences between U400 and SOZO devices to enable clinicians to understand the data when making the switch from U400 to SOZO. They were specifically looking for intra-reliability measurements across positions and between devices, also looking at repeatability of BIS measurements over time using SOZO, and the difference in impedance measurements for control and lymphedema groups across the 3 body positions, supine, sitting and standing, and the 2 devices, U400 and SOZO. They also examined the impedance ratio difference between the 2 devices. And finally, they looked at the relationship between ratios of impedance and L-Dex scores between a supine U400 measurement and a standing SOZO measurement. This was a cross-sectional study design with 100 participants, 47 healthy controls, and 53 breast cancer survivors. Of those 53, 14 were at risk of unilateral arm lymphedema, and 39 had been previously diagnosed with lymphedema. The U400 measurements were taking sitting, standing, and supine, and the SOZO were taking sitting and standing. For reproducibility, the seated and standing positions were taken at the same height and with the patient in the same position. For the supine measurements, the patients were measured lying face down, palms face down, and the patients were lying on a non-conductive examination bed. All measures were taken in triplicate and in the same order as described on the slide. The results showed both devices were found to have excellent reliability. They also found that comparison of BIS values at times 0 and 15 minutes with SOZO were highly correlated. They did show a difference between the impedance measurements between SOZO and U400 as expected. This is due to the difference in position of electrodes, but the differences were consistent across all measurement positions. When it came to impedance ratios between devices, there were no significant differences in ratios between the devices, regardless of which position or measurement condition. When the difference between ratios and L-Dex scores was examined, between the U400 and supine and SOZO standing, the study demonstrated that the 2 approaches were highly correlated, irrespective of whether the data was analysed as impedance ratios or L-Dex scores. So the conclusions were that both measurement approaches reliably measure arm impedance and L-Dex scores, but the 2 methods are not interchangeable. They showed a 3% equivalence, but that difference, although small, has the potential for misclassification of a small number of individuals when you're transferring between the devices. Therefore, the authors recommend to avoid using the 2 devices interchangeably, particularly for serial monitoring of patients in a prospective surveillance and early intervention model of care. So I hope this presentation has stepped you through a few of the relevant studies that demonstrate the utility of L-Dex, the benefits of prospective monitoring, and the difference between the U400 and SOZO devices. Thank you for your time.